Hi, I'm Don Pelto. Welcome to Podiatry Practice Mastery, and I have Rock here with me today. Welcome, Rock.
Hey, thanks, Don. Good to be here.
You're welcome. Didn't have a choice. I'm just joking. So,
Right.
Rock, I'm gonna take everyone up to date here. The backstory. We talked maybe a month or so ago about doing more in-office surgery, and I mentioned to you that in-office surgery is getting to be very in vogue within podiatry. People doing MIS cases or minimally invasive surgeries in their office. A lot of people are doing it for cash pay, and then you said, "Hey, Don, there's a way that potentially doctors could do this in office and get paid more than or at the same amount that they would be getting at the surgery center." And you did this
Right.
for like GI doctors over the years and things like that. So give me a quick kind of backstory on this kind of this amazing thing you found out.
Okay. Yeah, well, thanks. Yeah, my company is Rocket Healthcare Strategies, and Rocket with two T's, by the way. Rocket Healthcare, we've been in business for about 11 years, and we do work with practices on various ways to increase practice revenue and better manage their practice. So one of the key things that I've done, and I do, startup surgery centers too, but one of the key things I've done was work with gastroenterologists, starting out in the Chicago market, which is where I was for 30 years. Since then, I moved to Phoenix, but I started working with them and with Blue Cross, and we determined that that negotiated an arrangement with Blue Cross so that they would be able to do colonoscopies and upper endoscopy procedures in their offices for a higher fee. And so this kind of from the fee they were getting in a hospital, a professional fee they were getting in a hospital outpatient, to what they would get in a doing this in their own office. It's about 3x. It's a three times higher rate for the gastroenterologist. So then I started taking this around the country. So I've done this for gastroenterologists and a couple of other specialties in multiple states. The most recently, I've been talking with you about Massachusetts, and Massachusetts is very favorable because they are very big. Well, it's because of the intense regulations that literally prohibit surgery centers from being developed unless they're developed by a hospital system, yeah, by a hospital or a hospital system, so that they minimize the competition to hospitals. So by so doing, Blue Cross of Massachusetts and other local payers have been essentially incentivized to come up with a better solution, a solution that will, be more convenient, more cost for the patients, more cost effective for the payer as well as for the patients, and more cost effective for the providers. So it's a great solution with Massachusetts Blue Cross. They do this across all specialties, and so it's not just gastroenterology. We've done endovascular. I'm talking with pain management doctors, talking with you about possibilities with podiatry, and I've researched your procedures to see how this looks. So essentially, if you're doing, and there's several bunionectomy codes, of course, but if you're doing a bunionectomy, Medicare will pay about $1,000 more or less with for that procedure to be done in an office setting. And so there's a whole billing thing we won't get into, but anyway, there's about $1,000 to do a bunion procedure in the office. Blue Cross of Massachusetts will pay about $2,000 for the procedure to be done in an office. And this is the combination of the professional fee versus the facility fee. And that's really the issue here. Why would Blue Cross do this? Well, Blue Cross is, looking at facility fees that they have to pay to an outpatient hospital setting or to a surgery center, a state licensed surgery center, which are very expensive to build, as you know. And so by comparison, the accredited office setting is much less costly. for the health insurance companies. Not that we're worried about them, but but that's why they are coming to the table with this solution.
So Rock, it sounds like I don't know if you have the history of podiatry, but we kind of all pride ourselves on, in the past, no one let us into hospitals, right? So we did
Right.
all these hot clinic surgeries. No, we couldn't get in. Now we can get in, and we're all wanting to get out of the hospital because it's just a really slow turnaround time. It takes a long time, and a lot of us are going to surgery centers or just not doing surgery, or some are going into the hospital. So just to simplify, it sounds like we're almost accrediting our clinic to be a surgery center, kind of like that, right?
Well, yeah, it's comparable. It's comparable to that.
Comparable, and so it's comparable pay basically, because it's
Yes,
comparable.
yes, it is because Blue Cross of Massachusetts is willing to pay podiatrists, orthopedic surgeons, plastic surgeons, endovascular surgeons, gastroenterologists, pay them off of the surgery center fee schedule because
Okay.
there's about 5,000 CPT codes or procedures that can be done in surgery centers. So, yeah, they're essentially approving those procedures or nearly all of those procedures
Yeah.
to be done in an office setting.
So it sounds like, let's say we get 1,000 for the bunion. If we do it in our office with accredited, it's another 1,000 on top. And if they brought it to the surgery center, they may have to pay 2 or 3 times that. And so that's why they give us they're basically giving us a discount, but giving us a bonus.
That's
They're
right.
getting a discount, but giving us a bonus. Now,
Right.
this build out, now, is this something that would be appropriate if someone doesn't own their building? Like if you have a long-term lease, would
That's
you tend to
perfectly
want to
fine.
would you
Yeah.
tend to want to own the building? And in terms of, can you just convert a regular 12 by 12 treatment room into this, or do you have to have like this everything autoclaved with everything, how does that work, the setup?
Yeah, right. So yeah, you can do this in a lease space or own space. Doctors all over the country are able to do this in lease space or own space. The um, the setting, if you imagine, is that yes, you take a treatment room, if that's big enough for your operating table or operating chair, whatever you use, and it's adequate for you as the surgeon and your assistant
And
to
the
get
anesthetist, right? The nurse, you have to have
anesthetist. Yeah,
place in front for the nurse, for the
right,
head, right? For
right.
their equipment.
Right. So yeah. So yeah. It's I mean, and that's 12 by 12 is about 250 square feet, and that's a requirement for a procedure room in a surgery center is 250 square feet. So they can be somewhat. They can definitely be somewhat less. They can be more like a regular consultation room. So you've got those rooms. The need for space comes in more in recovery than in the procedure room itself. So the recovery space, if you've got, again, if you're doing these procedures in your office, you have an anesthesiologist or a nurse anesthetist there, you've got your assistants there, you want to fill up the schedule. You want to fill up that day with procedures. And in so doing, you need then adequate recovery space so that you're moving a patient out of a procedure room and into recovery as soon as the case is done. And so that really is the issue for space, is that if you've got a 250 square foot procedure room, then you may need 1,000 square feet for recovery space, because what you need to do there is have recovery bays, have a nurse's station, have a nurse that can watch these patients under recovery, so that I'll give you the example of a gastroenterologist, because their procedures are pretty quick. They have about 3 to 4 recovery bays per procedure room, so that there's no backup in the procedure room because they're moving them out of the procedure room into recovery.
Interesting. And this build out, I guess you could try to do it yourself. It's probably better to have someone to help you because of all the accreditations and approvals and things like that. Do you have
Right.
to buy the anesthesia stuff, or do they bring their stuff in? How does that work?
Oh yeah, they bring their own stuff in. If it's an
And they bill
anesthesiologist.
separately. You don't even have to pay. They
That's right.
bill
You
separately.
don't have to. Yeah, yeah. They bill separately. So they are. Yeah, if they're using propofol for anesthesia, it's a conscious sedation. It's not general anesthesia. If you can do these procedures under conscious sedation, moderate sedation, that's really preferable. the anesthesiologists are separate. You might have specimens that we need to send to the lab, so
Yep.
we can talk about arrangements with pathology labs where they essentially split up the payment between professional component and technical component. So there is a potential for revenue to the podiatrist on that also.
Because most of us already have pathology. We're doing biopsies and things like that. But I
Okay.
didn't. I always pay. I never knew I could make money off of that. I'm always paying money, or not paying. I'm just sending it out.
Right. Right.
Having
Well,
your own
there
lab
are,
knowledge.
perfectly legal arrangements for TCPC is what it's called.
What does that mean?
A
TCPC.
technical component, professional component. And
Okay.
so the lab portion, the creating the slide and so forth is the technical component. The professional component is is reading the slide in your office. And the pathologist comes in to read the slide. So that's where there's a potential revenue stream for you or any other physician,
Uh-huh.
any other
Uh-huh.
specialty.
Wow. Interesting. Yeah, I was. I think it's a great. I think it probably takes a little bit of patient flow. We were talking specifically about my case. I'm trying to avoid going to the OR right now, but amongst us, I think we must have at least 1 to 2 surgical days a week at the hospital with the other providers,
Okay.
So we have quite a bit of cases. I think I'm just saying what I feel. I think, we're used to being kind of served hand and foot there, and having like we have to get a C arm, of course, then we're gonna have to get all the instrumentation, and kind of figuring out, would the reps bring in their stuff, I guess, like they would typically bring in screw sets and things like that. Like in terms of hardware and things like that, would we pay for it, or they don't bill insurance, we would have to bill for that, it would have to be included in the facility fee, right?
Right. You would have to work that out with yeah, that would have to be a negotiate part of the negotiation with the fees that I've seen from Blue Cross of Massachusetts. I have not discussed these with Blue Cross of Mass yet, but the fees I've seen perhaps are inclusive of the hardware.
The
I'm not sure
hardware.
about that.
Yeah, because and then the joke is, you always do the cheapest hardware, right? So you have more. Like, can you do a K wire, or do you have to do a screw, or something
Right.
like that
Right.
for this? So you have to kind of figure out.
Yeah, so I think what makes sense to me, Don, is and to your audience is that there's potential with not every single health insurance company, but some health insurance companies are definitely open to this. And like you say, if you've got enough cases for 1 or 2 procedure days, probably 2 procedure days per week, then that to me is suggesting that you've got the volume to justify making the changes to your office space to accommodate this. It can be 1 procedure room or 2 procedure rooms. Sometimes the surgeons go back and forth so that the staff is doing the turning over the first procedure room. So the surgeon goes on to the next procedure room, and they essentially have cases that are back to back. It's a matter of efficiency and how best to get the productivity that you need to make this all work out. But I would say that in most of the cases that I've looked at, because I do a financial pro forma up front, and if that doesn't work, then we stop right there. But we do the financial pro forma to determine how things are going to work out financially with the volume of procedures and with the payers. If they're all Medicaid patients, it probably doesn't work. If you've got a fair amount of commercial patients, Medicare is adequate, but if you've got a fair amount of commercially insured patients, then that indicates to me that there's a very good potential, or cash pay, as you
Yeah,
suggest.
Rock. One thing I'm curious, and this is, I almost feel guilty saying this, okay, but I want to ask you. There are certain things that I could do at the hospital, but I currently do in the office. And so potentially those quick things could be done in this operatory room that we would have. Let me give some examples, some simple things. There's a
Okay.
simple procedure where I have a hammer toe and I just snip the tendon and I straighten it. It's called the flexor tenotomy, and it takes
Okay.
me literally a minute or two. Could you then, instead of just doing that in your office, could you bring it to your operatory? Or warts? I remove warts in my office. amputating toes. So you could amputate a toe in the office. You could just easily bring it, you would just schedule the time in
Yep.
that room, and then you would make a higher amount. But I don't know if all these don't need anesthesia. Is it okay if they don't have anesthesia, or are most of these, like,
Oh
these are
yeah,
big
it is
cases?
okay if they don't have anesthesia. Yeah, because these are
Okay.
the codes that I was looking at, and I think I mentioned to you earlier that there were, or separately, that there were 18 procedures that pay $1,000 or more,
Yeah.
for off of the Blue Cross of
Yeah, I saw
Massachusetts
that.
fee schedule. So there are lesser procedures that are going to pay, an extra $300 or $500 or whatever for the procedure to be done in office, because the insurance company is recognizing that you've got greater cost when you're doing these procedures in your office, right? You have labor costs and you have
Yeah.
equipment costs and so forth. So
Hmm.
yeah, I think there's a good range of procedures. But again, when I start a project like this, I do the financial analysis up front, the volume of procedures, per month, and then look at, how that works out, who the payers are, what percentage are commercially insured, Medicare, and so forth. Then we do get into accreditation, because accreditation is usually a requirement by the health insurance companies. Not always, depending upon what state you're in, but it is usually a requirement. And I have nurse managers who get involved in all the clinical aspects of accreditation. It's not a killer. It's not necessarily fun, but it's okay. Anybody can get through that. And then the contracting part with the health insurance company. So, hopefully we're contracted when we start the project. If not, then we can work through that after everything is set up and accredited.
That's interesting. I kind of, the conversation in my head is, I don't think our current spot is big enough. We own one of our condos, which there's just not enough room. But the other one, the lease is getting up, and so I'm thinking, heck, if you're going to get a new lease, you could lease with another 1,200 square feet. You can add on, and then when you're doing the build out, you could build this out. Now, what is the typical build out for like a 1,200? I don't know if you know prices, like what's it going to set us back, and how long is it going to take to recoup that investment? Is it like a 5 or 10 year recoup type of thing?
And no, I wouldn't say 5 or 10 years. It would be, it should be within 2 years. I would think, in terms of recouping the investment. Again, if you've got sufficient volume of cases, I would say within 2 years.
Probably
But
what? Probably like 80, 100,000, 80 to 100,000 for that build out.
right.
Yeah,
Right.
that's what I was
Yeah.
thinking.
Yeah. Probably something like that. It would not be terrible, but having tile flooring, or
You
washable
need
flooring, I'm saying.
C arm and stuff like that we don't
Yeah.
typically
The
have.
C-arm equipment, right. And then and then
And
the staff.
instrumentation, right? We would need more. We have certain more surgical sets we would have to buy and things like that.
Right. You would have to have a little bit more inventory of equipment, and then
Yeah.
the patient disposable items, you would have all of those items. So
Or,
yeah, there is.
you probably would still go to like the surgery center if you wanted to use a screw. You know what I'm saying? You probably wouldn't bring the screw in house. You probably cherry pick, right? I think you would
Yeah.
cherry
Oh,
pick.
yeah, definitely. Yeah. Cherry pick as far as which procedure, based upon the equipment and the hardware,
Yeah,
and
yeah,
which payer. Like I'm saying, I don't think you're going to do Medicaid cases, in your office. You can do
yeah.
Medicare cases, and they're going to be, minimally profitable. But you're really, but
And probably healthier patients, right? If you're having patients that are a train wreck,
oh,
you're probably not
definitely.
going to do them in your office.
Right. That's where the anesthesiologist is going to do, his or her evaluation of the status of the patient and their,
Okay.
ASA levels and so forth that
Yeah.
that they have.
Well, I think this was very curious. I think everyone's going to enjoy this. At the end, it just, if they want to learn more about where can they go to learn more?
They can go to rockethealthcare.com, rocket with two T's. If you want my if you want my email, it's ROCK at rockethealthcare.com with two T's. And then phone is 630-258-2211. Happy
Great.
to have a conversation with anybody about what they're doing now and what potential they see for their volume of cases and what they do.